Basically, today we are talking about the live view of the participant submission with the plans, and we get the feedback. But I'll try my best not to make it boring session. There will be some questions during the presentation and the live demonstration. Basically, this is my outline. I hope you can see my screen. Can you see my screen?
Yeah, we can see your screen.
Sure. So basically the outline will be before, during, and after planning. So we'll go and pause and understand the concept of that in each session. And then we talk about high quality plans and tricks in optimization. And lastly will be the live discussion about the submitted plans. So let's start first with the before, during, and after planning. And I would like to recall the CHOP acronym, which was first proposed by Dr. Raymond Mack at Brigham and Women's Hospital, Dana-Farber Cancer Institute in Boston, USA. So each letter stands for, let's say the C stands for contours, the B for beam arrangements or fields, C for coverage, the H for heterogeneity and hotspots, the O for organs at risks, and the P for prescription. For the contours, we review the target volumes and organ risk, which is the normal thing that we do. And for the beam arrangement, we have to make sure that we have appropriate and reasonable number and beam arrangement. For the coverage, we have to evaluate on graphic plan and DVH. For the heterogeneity and hotspots, we have to know the value and location. And for the organ risks, we have to review specific constraints corresponding those lines on plan and DVH according to the international standards like Quantac and so on. And for the prescription, we have to look for the total dose per fraction, and the image guidance imaging. So for the contours, usually this is the basic thing that we make sure that our user origin, which is the intersection of the BPs at the CT images, we make sure the CT names matches the name of the structure set, body contours full and there is no gaps. Structure naming, usually we would like to use the TG263, which is the standardizing nomenclature in radiation oncology. The couch structures should be inserted. Thin, medium, and thick depends on what site of body you are treating. Let's say for the pelvis region, usually we use the thick structure. For head and neck, usually we use the thin. And for most probably for the abdominal region, we use the medium. For IMRT or VMAT plans, make sure that you have the true body and not the automatic body from the automatic search. What do we mean by the true body and not the one that's being drawn by the system? So let's see this image. Usually when you are using a mask for the head and neck cases, you have a mask thickness of about 2 to 3 millimeters, depending on the manufacturer that you are using. So when you do the automatic body structure contouring, then usually the system is taking into consideration the mask itself, the mask thickness, which will be 2 millimeters outside the patient real anatomy. This will make really a big difference for you, especially if your target is close to the surface. You have to make sure that you use only the real anatomy of that patient and not including the mask itself. And you have to create your own structures for BTVs, rings, and so on. We don't touch the physician contours. Usually as planner or dosimeter, we create our own contours, and then we start from that to modify, play with it as we want. But the physician contours, usually we never touch. And you have to crop overlapping BTVs, I mean the optimization BTVs, to assure there is no contradictory in optimization constraints. Let's say you have BTV 66 and you have BTV 50. And for sure, your BTV 66 is enclosed with your BTV 50. And you are putting a maximum dose for the BTV 50 doesn't, let's say, the maximum should not be more than 105. And then you have BTV 66, which is like 140% of your BTV. How it comes? Then you have to crop your BTV, which is the BTV 50, including inside the BTV 66 itself. For the beam arrangement, there's a bunch of things, a lot of things actually. The course, treatment intent, modality, photons, electrons, technique, 3D IMRT, VMAT, body contouring, there's no gaps, as we said. For the field numbers, VMAT, usually we don't go beyond 4. IMRT, we don't go beyond 9. And the 3D, usually we don't go beyond 4, unless it's really needed. Field naming, again, we go to the nomenclature. So right anterior oblique, 1.1, and so on. It's good that you have something standardization. It will be easy for your colleagues to follow up what you have done. Machine, they should be same for all fields. You cannot have, let's say, 2 machines and every field from different machine. Isocenter, it should be same for all fields unless you are using a multi-isocenter. The jaw settings, the minimum should be 3x3. And for VMAT field, it's preferable that you don't exceed the jaw by 20x20. For the field monitor units, it should be greater than 5. The MLC should be added, and you have to check the fluence. And there's a lot of incidents happened. And in New York, one of them that the MLC was not added, and the patient being treated without and being overdosed, and some patients died because of that. If bolus, it should be added and linked to the field. A grid size, usually for SBRT and SRT, we are using 1 millimeter, and for others, less than 3 millimeters. VMAT fields, same number of each direction. Let's say you are using CW, the other one should be CW. So the same number will be, let's say, one arc CCW, another arc will be CW. You cannot use 2 arcs CCW because the machine will go back again without any unnecessarily. So it go back again to the same direction without exposing. So you're losing time. There is no need for that. IMRT fields, make sure that you don't have exact opposing fields. Otherwise, you are losing the optimization strength in that. Electron fields, you have to attach applicator, cutout, and so on. Tolerance table depends on technique. Energy 6, 15, 12E. Primary reference point matches the plan name. Dose rate for FF usually 600, and for triple F we're using more than 1,000. It reaches 2,400 for the 10 triple F. Set of fields, you should use MV, KV, CBC, depend on your protocol used in your department, and plan scheduling. And when you are treating an area in the neck or thorax, for example, one should ensure that the beams are not entering through the shoulders, arms, or exiting to the oral cavity unnecessarily. For intensity modulated radiation therapy, IMRT plans, one should consider the number of fields and their point of entry through the body and fluence pattern. Assessing the fields, arrangement, and collision may subsequently become important if target coverage or organ at risk, those limits are not optimal and may be improved with additional field or different beam entry angles. Taking the number of fields or arcs is also a key factor in the treatment time. A patient undergoing a palliative radiation treatment may not be able to lie on the treatment table for a long time, let's say. So the faster the treatment may be preferable. You should also consider that patient mobilization and internal organ motion are increased with longer treatment times. For the coverage, we check the BTV coverage as per protocols, plan quality indexes like homogeneity index, gradient index, conformity index, and so on, normalization point or to the value. If electrons, check the depth of reference. If a 3D, check reference point location. For VMAT and MRT, usually we use a virtual point unless you are using 3D or new calculation software, third-party software, then you have to use a location for that point, and the system can give you an indication what is the dose at that point. The problem with the DVH is that it should be used with a caution. The DVH cannot assess the appropriateness of the target and organ at risks. The DVH could report 100% coverage of the BTV, but the prescription dose and the BTV could be delineated incorrectly. Alternatively, 95% coverage of the BTV may not be met, but there may be a compromise between BTV coverage and organ at risk constraints, with an accepted sacrifice in the BT coverage itself to avoid unacceptable toxicity to the surrounding critical organ at risk. Let's say you have the brain tumor, and then you have the spinal cord, or you have the optic chiasm, then the physician could accept under coverage for your BTV, not to cause harm for that patient with regard to meet the constraints of the organ at risk. Furthermore, there may be excessive dose spillage throughout the structure, not reported within the DVH. Because this information cannot be obtained from the DVH alone, we recommend evaluating the 3D graphical plan qualitatively before proceeding to the DVH itself. For the heterogeneity and hotspots, you have to make sure that the heterogeneity correction is on, the hot and cold spot location, the dose spillage, split of dose between 50 to 60%, especially in the head and neck cases, in the oral cavity, spinal cord. This will make really a big difference for you and will reduce the spinal cord and the oral cavity dosage. Those fall off between the 50% and 90% ice dose lines, and this is usually used in the SBRT and SRT cases. Maybe some of you will be the first time to hear this acronym, which is the RVR, which is the remaining volume at risk, which is basically body minus BTV plus the organ at risks. Let's say you have brain tumor, so you have a lot of organ risk in the brain. Okay, what about the other structures like the lung, which is very far away from your location, right? Or the heart, or maybe the abdomen, or the liver, or the kidneys. So these are organs should receive 0 dose. You should make sure that there is no spillage in the inner and outer HU values of your couch. After determining the quantitative values of the cold and hot spots, it's critical to review their locations within the treatment plan. A hotspot within the GTV itself may be acceptable, as opposed to its being in the critical organ risks. Similarly, a cold spot at the edge of the BTV is preferred to being within the GTV or the CTV. So the physician could accept a cold spot at the edge of the BTV itself, but not to be inside the CTV or GTV. Why we accept this? Because we need to make sure that the organ risk doesn't exceed their tolerance level. For the organ risk, usually we are using the constraints, which is published internationally, like the Quantac R2EG protocols. And for the hypofractionated regimens, we are using the TG101. For example, a firm constraints for the optic pathway or spinal cord may be much more important to prevent blindness or paralysis than objectives for the parotid gland or oral cavity. And usually the troublemaker organs in the planning, they are the serial structures. The parallel structures, it's easy to deal with them because usually it's a volume or a mean. So most of the time you could achieve them. Your problem will be the maximum dose for the serial structures like the spinal cord, the optic chiasm, optic nerve, and so on. Again, the DVH doesn't provide information regarding the spatial distribution of those, as such as it is helpful to review the graphic plan to identify the location of the critical ice dose levels for each organ at risk. To find the values for organ at risk constraints, the most commonly used source for late effects in the conventional fractionation is the quantitative analysis of the normal tissue effect in the clinic, quantic data. And as we said, they have a fractionated regimen using the TG101. For the prescription, you have to match the plan name, image modality, treatment frequency, gating, are you using or no, bolus thickness location, break points, any notes by the radiation oncologist, plan schedule, treatment, patient-specific QA, document approval, and MU calculation, either 3D or manual. You must ensure that the total dose and dose per fraction are correctly entered. The treatment detail must also be specified, including the type of radiation, energy delivery, method, 3D, IMRT, VMAT, etc., and delivery schedule, weekdays, every other day, and so on. The image guidance of the setup verification imaging should be specified in the prescription image guidance requirements and techniques at time specified by the clinical protocols or the selected based on the size of the setup margins. By this, I finish the first part, and I will go to the next part, which is the high quality plan and tricks in optimization.
Hey, Bilal, can we take a moment just for a couple questions?
Sure. Yeah, sure. Go ahead.
We had 2 or 3 really good questions in the chat. The first one is related to taking the mask out of the body contour. Mm-hmm. In reality, the mask is going to be there during treatment. Mm-hmm. So how does taking it out of the body contour or leaving it in the body contour impact the plan and the plan quality and the plan calculation? Okay, excellent. This is a very good question. You know that the mask itself is not 100% matching or let's say there is no 0 gaps between the mask itself and the body. There is some gaps. And these gaps are the issue. It's not the mask itself. The mask is tissue equivalent, which is fine. This is what we are using. But the problem that there are gaps between the mask itself and the patient surface. These gaps are making trouble for us, especially in dose calculation nearby to the surface. If you do this, let's say your BTV is close to the surface and you push the optimizer too much to achieve the dose at that area, then you will have a hotspot, 120, 130, 125, something like this.
and you will be struggling all the time. You are trying to reduce the hotspot, but it's not going down. Or the dose coverage will be kind of, not really conformal. You will see some areas that have very hot dose and other areas very cold. Why? Because the surface of the mask itself is not uniform and not going with the patient body itself. And there are some gaps which prevent the dose calculation to be accurate at that area. So preferably for the VMAT and the IMRT to have at least your PTV 3 millimeters from the surface of the patient body itself.
Thank you for that. If there's more questions about that, we can address them at the end.
Sure.
The other question is related to using or why we don't use opposed fields with IMRT.
Yes. So let's say you have, 0-degree angle, and you have the opposing one is 180, right? And you do the optimization. What does the optimization in the IMRT do? IMRT is basically, it's a beamlets. So it divides the big field for you into small beams. So the optimizer will try to find the best entry for that beamlet to achieve the dose constraint without having issue with the exit itself. If the entry and the exit, they are the same, then the optimizer will not find an optimal goal for you. And the iteration will be going on and going on without finding a solution. So the IMRT, we are looking for global minima, the best goal for you to achieve your constraints. But having them 100% opposing, one of them is contradictory the other one. So the system kind of will lose its capability of finding the best solution for you in the optimization itself.
Awesome, thank you. I know I said we talk about it at the end, but
Sure.
Just this last question in the chat. Just to be clear about the part about the mask, you're advising not to take account of the mask.
Exactly. The advice is to exclude the mask itself from the contour and to contour only the body itself, because this is exactly what you have. The mask is tissue equivalent. 1 or 2 millimeter will not make difference for you. The issue for us is the gap between the mask itself and the patient body.
Awesome. Thank you.
Okay. Welcome. So shall we proceed? Okay, so we'll go for the second part of the talk, which is about the high quality plan and tricks in optimization. I will not spend much time here. It will be kind of a very fast review, and then we'll go into the details. So this is introduction about the VMAT. Most of you know this. This is a technique whereby the optimization begins with the very coarse sampling of our control points. And then as the optimization progresses, additional our control points are added, such as the final treatment plan has control points, which are sampled at gantry position approximately every 2 degrees. And this is the VMAT optimization algorithm. So you have the contouring and the arc geometry tool. You put them in the field setup. Then it catches your machine parameter. Is it HDMLC or it's normal MLC? It is Halcyon or whatever is your machine. And then it uses the MRDC, which is the multi-resolution dose calculation algorithm. And what objectives do you have? Constraints for them. And then it do optimization for the MLC control points, MUs per degree. And then it uses the calculation algorithm that you have, which is either XP or the AAA. And then it goes for the delivery. 3, in order to create plan for delivery, there are three parameters, which they are the MLC leaf speed, the gantry speed, and the dose rate. The MLC leaf speed is kept within a pre-specified maximum tolerance of 2.5 centimeters per second during the optimization. The gantry speed is then maximized at 5 degrees per second unless the required MU per degree exceed the maximum dose rate of 600 MUs per minute, in which case the gantry slows down to accommodate the required MU per degree. Let's say with this one, you have 1,200 MUs, and then you have the maximum dose rate that you use is 600 MUs. Your gantry speed is 5 degrees per second. What will the gantry do? It will reduce its speed to catch up with the high MUs that you are using. So what we advise you to use the FFF, use the high dose rate. Why you stuck yourself with 600 MUs? You are slowing the gantry speed to accommodate your MUs. Use the high dose rate, then everything will be back into normal speed. And the optimization levels, optimization performed in 4 resolution levels. The multi-resolution scheme applies to calculation directly only. the number of calculations directions double at each resolution level. So as you can see here, you have less number of calculation and resolution, sorry. Then the resolution here is double of this one. So this is level 1, level 2, level 3, and level 4. So level 1, let's say you have 50. Level 2, you will have 100. Level 3, you will have 200. Level 4, you will have 400. So each one of these levels double the other one of the resolution to find the fine tuning of your beam. The first one kind of will determine most of the things, and the next ones will be like, fine tuning. So now number of control points doesn't change, which is 178 control points. Algorithm flexibility preserved through optimization control points within single calculation direction merged into fluence for given calculation direction. The first level starts with a few arc segments, as we said before. First level offers a great flexibility, but low resolution. Next levels diminishes the flexibility, but improve the resolution. Each level goes through several steps. Within each step, machine limits and the calculation direction interface are gradually enforced. So we have MR level 1, MR level 2, MR level 3, MR level 4. As we've seen before, this is level 1, level 2, level 3, and level 4. So this is how the optimization works. So those gradient, let's say you have BTV 60 gray, which is the red one inside, and then you have BTV 70, the blue one outside, or the purple, whatever. So the rule of thumb, you need 1 millimeter to drop 2 grays. 1 millimeter to drop 2 grays. This is the rule of thumb. This may vary a bit and reach around 4 grays for hard optimization. So if you put more efforts in your optimization, you can achieve a 4 gray drop for each 1 millimeter. So let's say I have BTV 60 here and I have BTV 50. What's the difference between them? 10 grays, right? So according to this, I need 5 millimeters to drop from 60 gray to 50 gray. This is the normal one. But if I put, let's say, more hardness on my optimization, then I can reach 4 gray per 1 millimeter. So I need 2.5 millimeter to drop the dose from 60 gray to 50 gray. And this is very important, especially for head and neck cases. You need to use this. It's very important for you that you have a dose coverage properly, and also those gradient drop off from certain amount of dose to other amount of dose. This is very crucial, especially you are in the head and neck, you are talking about very challenging organ risk like spinal cord, optic chiasm, optic nerve, brainstem, and all of these. They are very critical organs and you must take care of them. And the 1 or 2 millimeters really makes a big difference. What we'll do with when we have like a large BTVs, like what we have in the head and neck, and even with the submitted cases, we have large volume. The optimizer will not do well. This is well known. With more than, as we mentioned in the beginning, more than 20 centimeter, the optimizer start not to do well, right? So what you will do? Basically, you will do something very nice. It's available in the Eclipse. I'm talking about Eclipse from Varian perspective. So we split the fields. So the first image here, we use half of the field and we leave 2 centimeter overlap. The other one will be the same. So you put like half beam block, okay? And then you leave 2 centimeter gap between the first arc and the second arc. Then you do the same again for 90-degree collimator. This is your gratitude, okay? And then this is your eye center here, exactly where I'm standing. So you give also 2 centimeter from here, and then you use all this area to optimize only half of your BTV in this side, which will be, let's say, the left side. And then half of your BTV will be talking about or concentrating on your right side. So this one will concentrate only on half of your BTV. This one will concentrate only on half your BTV. And this one will be concentrating half of your BTV. And this one will be concentrating half of your BTV. So here I have full 4 arcs, not 2, I have 4. But each one of them in concentrating only in a portion of your BTV. What would this will do? This will give the optimizer the maximum capability of taking care of the dose coverage and preventing any dose spillage. It also focuses on the BTV itself and allow a dose gradient. And as we said before, controls the dose spillage itself. And this is very beneficial for the long node chains. So large BTVs are challenging, and you should not exceed a jaw more than 30 centimeter for your optimizer to work. If your optimizer exceeds the 30 centimeter, the system will not work. The target AUTOCROP, which is a very nice feature available in Eclipse, in a plan optimizer, no more organ risk overlap or beam transmission. A good feature that automatically crops organ risk from the target during optimizer, eliminating the need to create separate cropped contours just for optimization. So you have your BTV, and you have overlap between the BTV and the organ risk. So you come here and you click on target AUTOCROP. The system automatically will generate artificial structures for the organ at risk and prevent the organ at risk itself to take the dose which is outside your BTV. So you can define how far you would like to be away from the overlap, like 5 millimeter, 2 millimeters, 0. It depends on you. By default, it is 5 millimeter, but you can customize this according to your needs. And I finished the second part, and we'll go for 3 poll questions, and I will post each one of these, and I need you please to have like 1 minute to answer these. Okay, so let's start the first one. What treatment site would most likely see a dosimetric benefit to increasing the number of VMAT arcs to more than 1? Lung, prostate, brain, head and neck. Tim, if you can kindly maybe watch on the chat and see the people responses, and then we can answer the question together.
Yeah, sure. So if everybody, we don't have the Zoom poll set up like normal, so.
No, sorry. It will be on the presentation itself directly.
Yeah, so I was just going to let them know if you guys would like to submit your answers, I'll try and see what's the most popular and see where we're at. Seems like pretty much everybody's saying head and neck.
Excellent, which is head and neck.
Great.
Due to the complex target volume and the frequent use of multiple prescription levels, as we have in this homework, the SIB plan, head and neck cases are most likely to see significant dosimetric improvement when using more than 1 VMAT arc. Okay. The next question, let me just put the options and then, okay. So a head and neck patient to be treated with 66 gray for the primary target and 54 gray for the lymph nodes as an SIB VMAT treatment. How far you will crop the optimized PTV 54 from the primary PTV? 1.2 centimeter, 1 centimeter, 0.6 centimeter, 0.5 centimeter.
I think that the primary answer coming in is 0.6, so letter C.
Exactly, that it's 0.6. So as we said, rule of thumb, you need 1 millimeter to drop 2 grays. So 66 minus 54 equal 12 gray. So 12 gray divided by 2, which is equal the 0.6 centimeter. Excellent. And the last question, a head and neck patient to be treated for the primary target and the lymph nodes as an SIB VMAT treatment. What is the maximum permissible opening for the X jaws? 40 centimeter, 30 centimeter, 22.5 centimeter, or 20 centimeter?
I think that it started out pretty close between B and D, but I think at the end of the day, B takes the cake.
Excellent. So we said this before. In order for your optimizer to work, your X jaws should not exceed 30 centimeters. Okay, so I finished part 2, and I leave now the door open for any questions for part 2 before we go to the live discussion about the submitted plan. If there are any questions, I'm happy to answer.
I think the only questions still correspond to like masks and couches being included when you're calculating the plan and how those are included. We already went over the mask, but if you want to touch on couch inclusion, that would be great.
Okay, so why we include the couch itself, right?
I guess, and how? Do we include it in the body contour, or are there other ways to account
Sure.
for the couch in the plan?
So what we do for the couch itself, we don't include it with the body contour. This is our practice in our institute. In other institutes, I see in other people, they are including it. So I'm talking about my experience, and I will tell you why I prefer my way. The other way is also fine, but it has some issues. Let's go for why we we are not using the couch itself as a part of the body control. We insert the couch itself. And as I said, we have 3 types of couches, the IGRT couches, sorry. We have the thin, thick, and medium. And we use the thin for the head and neck cases. We use the medium for the abdominal cases, and we use the thick one for the thick regions. And we just insert them and do the calculation. The couch, we calculate the transmission through the couch is like 2% of your dosage. So it's just 2%. It's not a big deal, but you need, as a medical physicist, you need to eliminate the error in your calculation. It should not exceed more than 5%. So if you exclude this one, or you did not include this one, then you have 2% out of the 5% just by the couch itself. What about the machine calibration? What about the ion chamber you have been using? What about the software itself that you are using? What about the patient setup? So there are a lot of errors that they could accumulate, sorry, and then you will exceed the permissible 5% for your dose discrepancy. Other centers, as I said, they are including it with the body. The problem that you have to be sure about the HU values of the inner and outer of your table. And this makes a big difference, especially, let's say, for critical organs or small volumes. So let's say if you have a BTV, a small BTV, and then you are including your table with the PTV itself, with the body itself, then this is a big issue if you are not sure about the HU values that you are using in your system. So you have to make sure that you calibrate your system, I mean the machine itself, the CBCT, and also your simulator CT. All of these should be calibrated and at a certain level, kind of very close in the HU values. Otherwise, you will have a problem with the dose calculation.
Great, thank you for that. I think we'll continue with that conversation and the mask conversation at the end, but I want to make sure we get through the live discussion as submitted plan, so we'll move ahead with that.
So now we'll go to the last session, which is the live discussion about the submitted plans. And we have head and neck case with 3 SIBs, BTV 54.12, BTV 59.4, and BTV 69.96. And the proposed or suggested beam arrangement was VMAT, 2 full arcs avoiding shoulders in optimization, counterclockwise with clockwise 180.1, 170.9, collimator control rotation if needed. For IMRT, 7 to 9 fields, avoiding going through the shoulders. And they provide you with a 3 beam arrangement, the typical 7 posterior beam arrangement, the typical butterfly with either 2 or 4 anterior beams. And they give you the room open. If you would like to use any different beam arrangement, you are welcome to do so, but please, you have to inform us what you are using. And for the head and neck case evaluation criteria, we have the targets itself, 3 for the targets, 2 for the CTVs, and then we have the organ risks, and we have the evaluation is 3 levels, level 1, level 2, and level 3. Level 1, which is the ideal, and you get the maximum mark if you get this or hit this. Then you have level 2, which is the guidance. You should be within this, and maybe you will get a mark or maybe 0 if you are reaching this, especially for the maximum dose. And for level 3, you will be there will be a penalty for you. So if you submit a plan and you reach level 3 in this, then maybe you have -1 or -2 in your plans. And for the plans I went through, some of them, they got -8.5 out of 25. So they did not even score 0. They score in minus because they all the time violate the level 3. And this is really a big issue. They should take care of what plans they are submitting. They should review their DVH very well. They should understand the organs at risk tolerances very well. Let me try to share just a second, please. Okay, so go here again. I need to share my screen. So just give me a minute, please, because I have 3 screens in the same time. Sorry for this. Just give me a second, please. I don't know why I'm not able to to share my entire screen. Should be a way.
There should be a way to share your entire screen.
Yes, I'm trying, but I'm not seeing the Zoom control itself. I'm seeing the window of the people, but I'm not seeing the Zoom itself. This is the issue. Okay.
Oh, is it? Do you have to press the exit minimized view?
I did this actually, but it's not allowing me. Sorry.
Yeah, I don't know if there's anything I can do from this side.
Yeah, this is the issue. I don't see the menu of the Zoom. This is the problem.
I'm gonna push this button that's gonna make you stop sharing your screen, and maybe that'll help.
Yes, yeah, exactly. If you can do this.
So I'm just gonna share a whiteboard real quick, and that should
Yes.
stop.
Yeah, exactly. It helps me now. Now I can see.
Okay, great.
Share screen should be.
And when you're going through these, one of the questions I think is pretty appropriate is for the high dose CTV 6996 or GTV 6996 and PTV, there's no CTV. So if you could just touch on why there wouldn't be a CTV for the high dose.
Sure.
That would be great. Or yeah.
So I hope you can see my screen.
Yeah, you're good to go now.
Excellent. Okay. So this is one of the plans submitted. And hope I can hide this one. Yes. Oops. I think it's clear. You can see the screen. So this is one of the guys who submitted a plan. He scored.
Can you maximize the prono window? The browser?
Yeah, but I need this to disappear. Okay. Now it's fine.
Yes, now it's fine. Yes.
Okay.
Thank you.
So this is one of the guys who submit the plan. He scored very well. He scored 23.98 out of 25. So almost 24 out of 25. He just lost very tiny things in his plan. His plan is excellent, actually. So we have the three BTVs. We go down here. So we can see BTV 59 and BTV 69.9 and the BTV 14. So the big one is the BTV 54.12. And then we have, this is the BTV 59.4. And the smallest one, the nodules, which is the BTV 69.6. And the most important thing that we concentrate on it is the 95% coverage for each BTV. So if you come here and we are looking for the 51.4 gray, which is this one. This is the 95% coverage of the 54.12, which is very nice. You can see he's covering the BTV in an excellent way without any issues. The problem here, he have these two, they should not touch each other. If you go to the 50% of the dose, which is 34 or 35 degrees, let's say, you can see this is the 50% of the dose. These two edges, they should not intersect. I should have a gap here. This gap will allow me to lower the spinal cord and also the oral cavity dosage. And here where he lost the points. He lost the points because he was on the edge of the spinal cord and also for the oral cavity constraints. Otherwise, the plan looks fine without any issues. You see the spine is being irritated for unnecessarily dose. So 50% of the dose is coming down here with no necessarily. Why? You are going down here. Why your 50% is reaching here? He's not using the ring in the proper way, or he's not using the normal tissue objectives in the proper way. This is one of the drawbacks. The rest is working fine. So if we go to the scorecards, you can see here, those of the spine, he did not reach the full mark. He reached good because he was about 35. So he exceeded the ideal and he went in the good region. So he lost kind of half mark here, more or less. And also here, where we have the mean dose for the submandibular glands, and we said we need to minimize the dose of the 50%. If he work well on this, he will achieve the full dose for the submandibular glands. And also the dose coverage for the 100% of the CTV 54 was not really good. He just got acceptable and he got 0. He should get the ideal, which will give him 1 point. So if he got the 1 point here and he got the fractions here, then he will get the full mark, which is 25 out of 25. This is one of the plans being submitted and it really did well. I'll show you one of the plans that was really a catastrophic plan, let's say, which scores minus 8.5 out of 25. So let me try to find it out. Okay, so browse. Yes, here. So this is the name of the plan. Just a second. Okay, so this is head. Yeah, this one. So if we go to the scorecards, you can see he scored minus 8.5 out of 25. And you can see that he did not pay attention for anything of the organ risk, nothing. So let's say the mean dose for the parotid, which was not acceptable, he got -2, he got 40. And the mean dose for the right side, the same thing. And also, if you go down to the mean dose for the brachial plexus, left and right, the same thing. Submandibular, also the same thing. And oral cavity, he could not achieve anything. And also the problem with the dose coverage, nothing been achieved, nothing, almost nothing. So the 69.96, the 54.9, and also the 54.12. I was surprised really to see such a plan without any, taking care the organ risk or the DVH. If he achieved the DVH, I said, okay, fine. He spent a lot of time working in the, working with the DVH itself, and he achieved the constraints, but he did not achieve the constraints for either the BTVs or the organ risk. And if you go to the DVH or even the dosage itself, you see the dose split all over, and he's going through the shoulders. And we inform them that please try to avoid the shoulders. So this will be rated for unnecessarily dose for no reason. And you can see even the 50%, it's almost reaching everywhere. So he did not use any avoidance. He did not use the normal tissue objectives. He did not use rings, nothing. The dose was spillage all over the patient body. And the third one will be the last case that I will discuss. When he achieved, let's say, 50% of the score. Let's try to browse again. Okay, so this one scored 12.98, if I'm not mistaken. So the scorecards. Yeah, exactly. So this is like half of the total score, 12.98, 13 kind of out of 25, so 52%. The problem was with the maximum dose to the brachial plexus minus, and also the dose coverage for the higher PTV, and also the dose coverage for the low PTV. It was not really covered. And also you can see here the volume of the BTV 69.96 was not covered properly. So here I lost, here I lost, here I lost, here I lost in minus, and I have penalty, then my score was bad. And as we mentioned before, in a lot of tricks, please use the rings, use the correct way of cropping your PTVs from each other, use your own optimization PTVs. For the gantry angles, for the arcs, I advise you to use 1 degree or 2 degree offset between the gantry angles. What does it mean? Let's say you started with 178 to 181 counterclockwise. The other one will be, instead 181, it will be 182, 177. So make an offset 1 or 2 degrees between the arc rotations. This will allow you to have double the control points. We said we have 178 control points per arc, right? So if you reverse direction, it's still the same. You are going through the reverse direction, but you are keeping the same control points. But if you use the 1 degree or 2 degrees offset, then you will have more control points. You are like doubling your control points, and you will achieve better conformality in your dose gradient. Use the normal tissue objectives. It's very important, and maybe we can talk about this in details. There is a lot of things embedded in the normal tissue objectives. You have to know which parameters are there, what to use, how to drop the dose at the edges, and so on. Also the rings, they are very, very important to use them. And please remember, the mean dose is the easiest one to achieve, and the hardest one is the maximum dose, which goes to the serial objectives. With this, I would like to stop because I think I have 4 minutes or 3 minutes remaining. And if there are any questions, I'll try my best to answer them within this short period of time. Thank you very much.
Great. Thank you so much, Bilal. If you have more than just the 3 minutes remaining, we can stay a little bit longer. That's up to you, I guess.
That's fine. I'm okay.
To continue the conversation. I think
Sure.
that there
Mhm.
were definitely some questions. Let's just go with one from Gazim about scheduling the boost fractionation for VMAT. They asked, should boost fractions be included together with PTVs or separate? So basically SIBs or sequential boost volumes, if you could talk a little bit about that.
Okay, so the SIB, basically you have the same PTV. One of them is high risk. The other one is medium risk. Let's say the case that we have three PTVs, right? We have high risk, medium risk, and intermediate risk and low risk. The high risk was the 69.96. So you need, this is the high risk one. And then the intermediate was 59.40. And the low risk was 54.12. So what we prescribe to the high risk volume. So this is what we did in the presentation. If I can you please stop the sharing of my screen? Excellent. Okay.
There you go.
So just a second. So if I go here, and then here, okay. You can see my screen, right? Do you see my screen?
Right now we don't see your screen.
Okay, I need to share. Right, you're right. I have three screens. I hate it anyways. Now you see, right?
Yeah, there we can see it. Thank you.
Okay. So we have these three BTVs that you have in the SIB homework. So we prescribe to the maximum dose to this. So it is 33 fractions multiplied by this one equals this one. So you are delivering 33 fractions with high dose, 2.212 centigrade. This one also, it's the same thing, 33 fractions, and this one is 33 fractions. But the dose per fraction for this one, for the biological effect, will be 164. For this one will be 180 centigrade. So this one's called the high risk, intermediate risk, and low risk BTVs. So we usually prescribe to this one. So your prescription dose will be to the maximum or to the boost one in the SIB, not to this one, because some centers I've seen them, they prescribe by mistake to the lowest dose, which is not correct. You are using SIB, then you have to prescribe to the highest dose that you are using.
Then a question,
Sure.
Kaidre. Then the PTV 69.96 becomes our target in the plan. That is the plan target. Isn't it?
Yes, you have three BTVs in your plan target. You have the BTV 69.96, BTV 59.4, and BTV 54.12. One is the lymph nodes, one is the primary or the GTV itself, and one is the lymph node in the upside of the brain itself, or the head and neck itself.
Yes.
So you have to concentrate on three of these, not only one. Three of these should be concentrated.
Okay, thank you.
You're welcome.
Following along with that, we have a question from Ajay. And just quickly, if the dose, is there a minimum dose per fraction that should be prescribed? Let's say is 150 centigrade, or can we go lower for something in a head and neck plan?
Sure. So usually for the biological effectiveness, you should not go beyond 150. 150 should be your cutoff value, kind of. And your maximum also should not exceed 250. So it should be between 150 and 250. This is how they balance it in biological effectiveness. And also this goes back to your school and also to your protocol in your institution. Some institutions, they are using different protocols. So I cannot generalize this, but what we are using at our practice and what I have seen others, they are using between 150 to 250 is the maximum.
Awesome, thank you. We have two questions about SRS. One, can you just talk about dose rate with SRS? Is 600 dose rate okay, or what might be the problems with that?
Okay, sure. So for the SRS, usually you are delivering high amount of MUs, let's say 21 grays, maybe in one fraction, or let's say 21 grays in 3 fractions. So you can use 21 as single fraction, so 21 gray, single fraction, or 21 in 3 fractions, so you have 7 grays per fraction. So if you use the 600 MUs per minute, then the treatment time will be very long, because your 600 MUs is not enough to deliver your 21 grays in the full rotation of your arc. So the arc, instead of taking 1 minute, let's say, or 1 minute and 12 seconds, it may take like 3 or 4 minutes. Because as we said before, the gantry speed is 5 degrees per second, and it will slow down if your dose rate exceeds 600 MUs per minute, right? So you are now asking the system to boost and give 21 gray or 700 centigrades, let's say if you are using a fractionation dose, to deliver that amount of dose in 600 mUs per minute regimen. So for sure, there will be longer treatment time, and maybe your your patient is not tolerable to stay on the couch for that longer time. So instead of finishing the treatment in 3-5 minutes, then you need double of that, like you need 10 or 15 minutes. And then here again, the patient may move during this, then you will have an issue with the embolization and also the intra-fraction motion. So there is a lot of errors may happen if your patient stays longer on the table itself. So we prefer that you use with the high dose rate, especially for SRS. So you go, the 6FFF from Varian is capable to deliver 1,400 mUs per minute for the 6FFF, and the 10FFF is 2,400 mUs per minute. So it depends on the site you are using. I treated a few weeks back a spine patient, 21 gray, one shot. I used the 10FFF because the delivery was very fast. And within a couple of minutes, the patient finished the treatment and with excellent coverage, and was very homogeneous without any issues. So usually with SRS SBRT, we prefer to use the high dose rate to minimize the time treatment on the patient, on the couch itself.
Great, thank you. This question just came up. Just SIBs and head and neck, the same process. Would you use the same process for cropping the different level PTVs as you do in head and neck for other sites such as prostate?
Okay, excellent question. No, I don't. Usually for head and neck, as I told you, the rule of thumb is 2 grays per 1 millimeter. But if you put more burden in your optimizer, you can reach up to 4 grays per millimeter. So this is usually what I do in my institution. I kind of challenge the optimizer itself, put a lot of constraints, and I reached excellent plans with 4 grays dropped by 1 millimeter. For the pelvis or the abdominal region, you have your BTVs a bit larger. So the 2 grays per 1 millimeter is a good approach.
Great. That's a wonderful answer. In general, I guess the cropping of the structures is the same, but the margins that you use, the distance you're cropping would be different for the different sites.
Exactly, yeah.
Okay. And now we can go back to the mask and the couch. Some people were asking specifically about in SRS. Do you need to include the mask in SRS?
Yes, and this is a different story. If you are using an SRS mask, this is a totally different story. I spoke about general head and neck cases. I did not spoke about the SRS itself. The SRS itself, no, the mask should be included. It should be contoured with the body itself because it is there and it's calculated with the system, and you can insert exactly the same SRS mask into your contours. So this one should be contoured with your body of the patient itself. This is a special thing. It's not as the general treatment of head and neck cases. And my advice for head and neck cases to use 3 arcs, 2 full arcs, and the third one will be 90 degrees collimator rotation. The third one will do like fine tuning. It will make the splitting. So it will make the MLC goes with the same direction of the trachea itself, and it will remove the dose from the spine. And it make your BTVs not, let's say, touching each other's in terms of dosage. I mean, dose coverage will not, there will be a splitting between them, as I showed you in the plan, the excellent plan actually being submitted. He could do this easily with using the third arc and put some effort on the optimizer. Then he will exactly make the 50% doesn't reach, intersect from the left side to the right side and up and down.
Fantastic. I answered another question in the chat.
Sure.
How does the 4 gray per millimeter gradient that you're looking for, how does that impact the MU number and your plan complexity, and how you evaluate that plan as a physicist?
Also an excellent question. Yes, it will increase your MUs for sure. If you put more burden in your optimizer, this will boom your MUs, but it's not, let's say, significant booming. Maybe like, let's say if you have 600 monitor unit, it will reach 640, 650, something like this, sometimes 700. So it will be like 10% of your MUs. but it will give you an excellent dose dose control from the periphery of your PTV to the surrounding tissues. This is very crucial. So I don't mind to spend another 15 seconds on the treatment while I'm achieving excellent dose coverage and protecting my organ at risks. Some people will say, oh, the integral dose will be a little bit higher. No, it's not that much really. So it's less than 5 to 10% for the worst case scenario. So sometimes you have to make compromise between things to achieve the goal.
And do you have a suggestion for what your IMRT factor would be? And that's the MU divided by the dose per fraction for head and neck.
For head and neck, usually it's 3.5 something. It reach up to 5. So from 3.5 up to 5. So more or less, this is your factor, what you are talking about.
Great. We'll ask maybe 2 or 3 more questions, and then I think we'll call it a day. We don't want to stay here too long. All these questions are fantastic. So when you make a head and neck plan, do you typically use flattened beam, or can you use a triple F?
Okay, a triple F has a limitation. You should be aware of that. When you increase your BTV volume, your triple F fails, because your triple F is like a triangle, right? It's not flat beam. It's a free flattening filter. So with larger BTV, for sure, your triple F will fail. So usually with the head and neck cases, we don't need a triple F, because usually triple F is used for high dose rate. For higher dose rate, like SRS and ART, to reduce the time for treatment. But for head and neck, usually I use the 6X and it works without any problems for me. I don't see that there is a need for triple F, unless it's a very small volume, or maybe 2 volumes, not that big. Doesn't exceed 10 centimeter, let's say, just to be more practical. More than this, no, I don't use the triple F for that.
Great, yeah. So there is the technological limitation of the way the beam is shaped.
Yeah.
I think the last 2 questions we'll go over today are Halcyon specific. The first one is for Halcyon, is there a specific couch specification, or what should you use, do you know, for a Halcyon when you're doing your plans?
This is totally different story. It's more or less, I make it like a tomotherapy machine. It's a linear tomotherapy. Let's say make it like this. So it's totally different story. I don't have that much experience in that, but I know from my colleagues that they are using the specific couch insertion for the Halcyon. But I've never, let's say, have hands-on on the Halcyon itself, but it's totally different story. It's different from the normal NID.
Yeah, I think in that case, the best resource would probably just be to contact, if you can, Varian, or I don't know if anyone associated with RCC has a lot of experience with Halcyon. I think there's a few people who might be able to get that answer. We'll see if we can get Caroline to follow up on that. Sure. And then the other one was also a Halcyon related question. I think you can do SRS or SRT technically on the Halcyon.
You can, because the MLC is not MLC. It is virtual MLC, and it reaches 4 millimeter thickness with a virtual ray. So it's not really a physical 0.4, it's a virtual one. And a lot of people have debate about, can you really use it for a small volume for SRS SPRT or no? There's a debate. Some schools, they say, yeah, you can use, and other people, they say, no, you cannot, because it should be at least 2.5 or 3 millimeters maximum to be capable of treating very small tumors with SRS or SPRT.
Yeah, and then of course the Halcyon's locked to no couch rotations.
Exactly.
And the 800 per minute dose rate.
Yes.
So it is possible, but those are limitations, and it sounds like there's some discussion within the community of whether it's a good idea or not.
Exactly.
Great. So with that,
I will reach the conclusion. So treatment planning is a black box, and you need to utilize it to its maximum capability. We are producing a high quality plans, and our focus is patient safety and benefits. And I would like to recall this saying, I hear and I forget, I see and I remember, I practice and I learn. So I advise people, practice, practice, practice. This is how we learn.